All right, assalamu alaikum everyone. My name is Ibrahim Albalkhi, and I'm your colleague in fourth year, and today I'll be explaining a clinical lecture on dizziness and vertigo. So let's start. Before we start, let's start by defining some terms. Now, usually when you think of vertigo, it's very important to understand what you're talking about. Similar terms that might confuse students are syncope, seizures, dizziness, imbalance, lightheadedness. So let's start and define each one of them. So seizures, you're probably familiar with seizures. So it's the rhythmic movement, convulsions. It's due to hyperactivity of certain parts of the brain. There isn't necessarily loss of consciousness, so this isn't 100% correct, but sometimes there is, okay. Syncope happens when you don't have enough blood flow to the brain, so you faint and you lose consciousness. Exactly. Dizziness in Arabic means doha, okay? And imbalance means losing balance. And lastly, vertigo means that you see something is moving when it's not, okay? Another way to define them, so we said dizziness is another word for lightheadedness. You feel everything is swimming. Vertigo, you feel like something is moving. You can also call it spinning. Gait imbalance just describes that you're unable to walk. And this can be due to vertigo or due to dizziness. So ataxia is, so basically you can't coordinate purposeful movements. So you want to touch something, you want to catch something, but you can't because you have dysfunction probably in the cerebellum. And these are all signs, okay? These are not diagnoses. So you can't diagnose someone with dizziness or with vertigo, but they will help you come about with a diagnosis. So what causes all of these? We can't really pinpoint it to one system. It's usually to different systems. So cardiovascular problems, if you don't have enough blood flow, these can cause syncope or loss of consciousness. Otologic problems, I'll talk about more about this in a second. So basically your inner ear is responsible not just for hearing, but also for your balance. And I'll explain it in a bit. Neurologic, now, as you know, you have certain columns in the spinal cord for proprioception. They tell you where to go, where to your current position. And without these, you will become, lose coordination. Or it can be due to a systemic process, okay? So when a patient comes to you as a future doctor and says, I'm dizzy, the first thing you do, always, whenever a patient comes to you, you have to do the following. So chief complaint, history, physical exam, labs, and imaging, usually, okay? It's not always like that, but these are the 4 critical principles to any patient approach. So let's start with history. Basically, you want to go over Socrates. Now, I know you learned that it's just for pain, but you can literally use it for anything. So let's start with sight. Obviously, you can't use sight for dizziness, so you move on. Let's start with onset. So when did the dizziness start? Did it happen before? You move on to character. Character is very important. You ask whether it was continuous or episodic. For how long is each episode? How would you describe it? Because you want to differentiate between lightheadedness and vertigo. Do you lose consciousness? These are all part of the character. There isn't any radiating symptoms, so you move on to the associated symptoms. Is there any hearing loss or ringing tone in the ears? Do you have any other symptoms such as focal, neurological deficit, weakness, loss of sensation? These all will help you towards a certain diagnosis. You're gonna understand this more as we go through the lecture. So let's start with a little bit of orientation. Now, you know your inner ear has 2 parts. So you have your inner ear part, which is responsible for the for carrying the sound. So as you know, this is the stapes. Okay, this is the stapes bone. It's like that. Okay, and it's attached to a part of the inner ear, which there's fluid here. And as the sound is carried by the inner ear, it will move fluid, which will then be transmitted through cranial nerve 8 into the brainstem, and you will decode that into sound, basically. Around this canal in the inner ear, you have another area of fluid. You learn this more in head and neck. And this one is responsible for the motion, basically, okay? And then it will be attached to cranial nerve 8, but the vestibular part of cranial number 8, and it's responsible for the motion, okay? So within these canals, you have these receptors. So imagine this is a canal with endolymph, okay? Endolymph is basically fluid. And as you turn around, as you move, as you do anything, the fluid inside these canals will move. And as it moves, it will push against these receptors. And this is interpreted as firing frequency. So if there's a lot of movement, you have a lot of activation. If there's a little bit of movement, you have slow or low activation. And with millions of these receptors in your inner ear, you're oriented to direction, okay? I hope, so just know that there are receptors, special receptors. You'll learn more about them and later, and they're found in the inner ear. Now, as you know, this is a general appearance of the tympanic membrane. You're looking from the external ear inward, and these are the bones which are attached to the tympanic membrane. As the tympanic membrane vibrates, the 3 bones vibrate, the 1, 2, 3 bones vibrate, and then they're attached to a certain endolymph, which I've shown you. It will move the fluid. You get sound. Around this fluid, you have further fluid, okay, which is responsible for the motion. I'm going to show you a picture at the end of the lecture, which will make this very obvious. We're just saying that the inner ear has 2 functions, so sound and balance. Okay, so let's talk about the balance. Now, as you know, how do you know as a person that you are in a certain position or direction? You rely on your visual stimulus, your proprioception through peripheral proprioceptive sensory receptors, and through the endolymph, through the vestibular nerve, okay? These all will come together and will let you know you're at a certain direction, okay? So I'm going to explain everything, and then at the end, I'm going to tell you, no, focus on this, and these are the things they ask about. But I'm going to do that for the full transparency, okay? So a very important reflex that exists is called the vestibulo-ocular reflex. Let's break it down. So this means that it involves cranial nerve 8, and this is cranial nerve 3 and 6, okay? Because it involves the eyes, eye movement. And basically what happens, as you turn your head, okay, so I'm looking at the screen. As I turn my head, my eyes are still looking at the screen. If I look the other way, my eyes are still looking at the screen. And this is due to a very complex pathway, which I'll explain in a bit. So basically, as you move, the fluid in the endolymph in the inner ear will move. It will carry signals to the brainstem. The brainstem will then relay. So if you move your head to the left, okay, you want your eyes to turn to the right. So you want your right eye to contract its lateral rectus muscle. So you want to activate the lateral rectus of the right eye. So you want to activate the 6th cranial nerve. So activate the abducent nucleus. But at the same time, you don't want to activate the lateral rectus of the left eye, or else you're going to get your eyes separated. You don't want that, okay? You want the, what's it called? The oculomotor nerve to be activated. So there's this nerve fiber, it's called the medial longitudinal fasciculus, and it's very important. Once the abducent nerve nuclei is activated, this medial longitudinal fasciculus is going to carry signals to the 3rd oculomotor nucleus, or cranial nerve 3, and you're going to get activation and hence the medial rectus contraction. And this is the reflex, basically. So as you turn your head in a certain way, your eyes are going to stay the same. Any problem in this reflex, what's going to happen is you're going to tell a patient to look straight, and then you're going to thrust their head in a certain way. What's going to happen is they don't have this reflex, they have brainstem damage or vestibular nerve damage or whatever, is that, so they're looking, and then you turn their head, their eyes are going to turn with their head. And then they're going to correctively, and they're going to correct their eyes to look at the screen. While a normal person, he's looking at the screen, you turn his head, his eye is still looking at the screen due to this reflex, okay? This is more explained here. So in order to assess whether this reflex exists, so if this reflex works, this tells you that the patient does not have any abnormality in the brainstem related to cranial nerve 8 and cranial nerve 3. And this is very important in the physical exam part of the assessment for vertigo. Okay, different tests that you can do. So you can ask the patient to read a book while walking. Now, as you walk, your head is turning everywhere and you want your eyes to stay steady. So this is why this reflex is very important. Now, if there is a case where you have bilateral damage to this reflex, so it does not work bilaterally, you can assume that as the patient is walking, his head is moving, so will his eyes, so he can't read, okay? So that's further explained. So if a patient tells you, I can't read while walking, that probably tells you that he has bilateral loss of the vestibulo-ocular reflex. This is all for you to understand. Now, another test that you can do, you can ask the patient to read a Snellen card, acuity card. So you've probably all seen this before. So usually when he's steady, if he had a 20/20 vision, he should be able to read this letters, okay? But if he starts walking, it's going to be harder for him, صح? But luckily, you have this vestibulo-ocular reflex that's going to help him to read it despite walking, okay? At worst, he might have a loss of one line. So he'll be able to read this instead of the last one, which is this, okay? This is at worst. But if he had bilateral vestibular damage, so you don't have corrective vision and his eyes are moving everywhere, so he will lose 5 lines. So he will not be able to read this or this or this. He might be able to read this, okay? Instead of the normal, which is 1 line loss. So again, this is a test to help you assess whether you have bilateral damage to the vestibulo-ocular reflex, and if can further tell you whether help you in the diagnosis of vertigo. Other tests, so we've talked about history, we've talked about simple physiology. We're going to continue through the tests. The most important thing about the test is to know when is each used and why, okay? So just know the basic principle, okay? You don't have to memorize. In clinical lectures, you just know basic principles of clinically relevant tests. Another test you probably know is the Romberg test and tandem walking. Now these assess for another, so I told you in order to be oriented to time and place and position, you need visual stimulus, you need proprioceptive stimulus, and you need the vestibular stimulus. So the proprioception is an important and crucial part. And in it, you will use, to test the dorsal lemniscal pathway, you can use the point testing or the Romberg test. So you ask the patient for their Romberg test, you ask the patient to close their eyes and bring their feet together. And then since they lose the visual stimulus, you're mainly relying on their proprioceptive stimulus. And if they have any damage in the dorsal lemniscal pathway, they will not be able to balance, okay? Tandem walking, you ask them to put heel to toe and walk. This will help you assess the dorsal lemniscal pathway. If he can do both, that means his spinal cord dorsal column is all right, and you should test something else. Okay, as I said, in the Romberg test, you ask him to close his eyes, and he will no longer be able to balance. And it will tell you that he has a dorsal lesion, dorsal column lesion, if it's positive. Now, compared to cerebellar ataxia is not tested by Romberg test. So Romberg test is just for the dorsal column, okay? If you had a lesion in the cerebellum, you'll be standing still, but you will not be able to coordinate while your eyes are open, okay? So as you know, the dorsal column is responsible for the conscious proprioception, okay? While the cerebellum is responsible for the unconscious proprioception. So you'll be standing still, but since you don't have unconscious proprioception, you might be standing in a tilted way. So your head will be like this, or your body and trunk will be in a different position because you can't coordinate it unconsciously. Luckily, your cerebellum is there and you're able to stand in a good place. The point is that the Romberg test is important for the dorsal column assessment and not for the cerebellar assessment. We will see how to assess the cerebellum in a bit. Just 1 second. Okay. Okay, so another test is the head thrust, as I told you. So you ask the patient to look straight, and then you ask them to thrust their head this direction, okay? And they're looking at the laptop, for instance, okay? If their vestibulo-ocular reflex is working, they should be able to maintain eye contact. If not, their eyes are going to turn with the head, and then he's going to consciously move them towards the laptop, okay? This is called corrective saccade, okay? Where is it? Yeah, catch-up saccade, okay? So he's correcting the eye movement by looking at the laptop again, or the thing you asked him to look at. And usually see this if you have any problem in the vestibulo-ocular reflex. So if you have a vestibular nerve damage due to inflammation, gentamicin, ototoxicity, it can be due to idiopathic or autoimmune damage. Now, you don't have to know these per se, but you have to understand the concept. So any damage to the cranial nerve 8 or the brainstem can eventually result in damage to the vestibulo-ocular reflex, which you can test by the head thrust test, okay? It's positive if there is corrective saccade, which means you turn his head, the eyes move, and then they correct by themselves instead of staying. I have a video on this. I think so. Okay, I'll show you the videos at the end. So let's talk about vertigo. Now we have the physical exam done, the history done. Let's talk about vertigo. Now, a patient will be sitting still and he'll imagine that the world is moving around him, okay? But the world is not moving. So it's a sensation of motion without actual motion. It's exaggeration in motion perception. And it's divided into two parts, central and peripheral. Peripheral basically involves the peripheral nerve, so cranial nerve 8, or the inner ear, while central involves the brainstem, okay? And it's very important to differentiate between the two. So this is the first slide they usually ask you about. So the difference between the peripheral and central vertigo. So for peripheral, we said it's damage to the nerve itself or the inner ear. Central is usually to the cranial nerve 8 nuclei, so on the brainstem. And they differ in symptoms. So peripheral damage is usually sudden. As you can imagine also, since the cranial nerve 8 contains both the cochlear and the vestibular part, if you have damage to the nerve, you'll probably have hearing loss or tinnitus. This is not the case for central. If you have the damage for cranial nerve 8 nuclei in the brainstem, then you might not have any auditory symptoms. Nystagmus. So what's nystagmus basically? Nystagmus is basically when you have the eye movement, the eye will be shaking, okay? I'll show it to you in a bit. And why is that? Because as we said, the vestibular system is connected to the oculomotor system through the vestibulo-ocular reflex. If there is improper coordination between these two systems, you can imagine everything can go wrong, and this is where you usually see nystagmus. So let me try and show you nystagmus. Let me share my screen. Okay. Let's see that. So I prepared a video. So in this case, I'm going to show you, and this is going to be nystagmus, okay? Look at his eye. You see how it's shaking? You see how his eye is shaking a little bit? And now it's this one. It's shaking instead of staying in place. This is nystagmus basically, and it indicates that the patient probably has a problem in the vestibulo-ocular reflex, okay? So you need to double check that to identify the cause. Let's get back to the presentation. So it's present in both, whether it's central or peripheral. Nausea and vomiting. Usually, when you have peripheral damage, you get improper signals. So you feel like you feel nauseated, okay? But I would say it happens in both. However, it's more common in the peripheral, okay? Differentiating between the peripheral and central is very important. There are other signs, which I'll explain a little bit. So peripheral, as I said, it's due to this is the inner ear, basically. It's responsible for sound and the vestibular system for balance. If it's damaged along with the peripheral nerve, okay, that's called peripheral vertigo. If the brainstem is damaged, then that's central vertigo, and differentiating is important. Peripheral is associated with tinnitus, as we said. Okay, some differentials is benign paroxysmal positional vertigo. I'll talk about it in the end. Labyrinthitis, if you have inflammation of this organ. Meniere's disease, we'll talk about it. Herpes zoster, if you have a herpes infection of the cranial nerve 8, it can cause peripheral vertigo. Central, you'd assume stroke, anything related to stroke, so ischemia, hemorrhage, multiple sclerosis, which is a CNS demyelinating disorder. These are all differentials for central. Now, this is very important. So we've talked that peripheral are usually sudden, and we've said that it's associated with hearing loss. What's more is when we look at the nature of the nystagmus, when you have peripheral vertigo or peripheral nystagmus, so peripheral vertigo and peripheral nystagmus, I want you to think of them as the same thing. So when you have peripheral vertigo, the nystagmus is usually right and left. So the eye moves right and left, okay? However, if you had central, the eye will be moving right and left and up and down, okay? And that's how you differentiate. So if the nystagmus was vertical in nature, that will hint towards a central lesion, okay? And if it was peripheral in nature, that would hint towards, if it was horizontal in nature, it can be both. So you can't tell and you need further testing, okay? These pharyngeal goggles are very important. So basically ask the patient to wear these goggles, which make the eye bigger, okay? And now, since the eyes are bigger, instead of, as I showed you in the video, the eye movement was very minimal. So you can't see it, okay? But when you wear these goggles, you're able to see the eye movement at a better scale, okay? Usually peripheral vertigo is suppressed by visual fixation. So if I tell the patient to look at this object and focus on it, the nystagmus will go. So the eye shaking basically will stop. However, if you compare that to the central vertigo, it cannot be stopped. There will always constantly be nystagmus during the episode, and it can be vertical. Okay, so this is one important differential. Okay, when it's vertical, it's most likely central. Okay. Now, as we said, there are different causes to vertigo. Vestibular neuritis. Itis means that there's inflammation in the vestibular nerve, labyrinthitis. So basically the vestibular system in the inner ear is inflamed. If you had stroke, this is central vertigo, or hemorrhage, cerebellar hemorrhage can also cause vertigo. It can be due to multiple sclerosis, and the rest of these are not important for your current stage, okay? Okay, so now you probably have an idea about the different causes of vertigo. It's important to put a differential diagnosis in mind when a patient presents to you with vertigo, okay? And this is the second important slide. So we've talked about the first important slide. This is the second one, the differentials for vertigo, okay? We're dividing them based on whether there is hearing involvement and whether there isn't, okay? And the duration of the episode, okay? So if a patient comes to you and tells you, I feel like the world is moving for a few seconds, you'd probably be thinking of the perilymphatic fistula or benign paroxysmal vertigo or the inflammation, okay? Vestibular neuritis. Now, usually, okay, the ones that I want you to focus on are PPPV and Meniere's disease, okay? These are very important to differentiate. Perilymphatic fistula, basically, as I said, you have your inner ear, it has fluid, okay? If the fluid leaks out of the inner ear, you can imagine that creates problems and you'll get vertigo because you don't have enough, the vestibular system is not working. So the fistula basically means that the fluid inside the inner ear is leaking. The episode will be for a few seconds and you will have a hearing loss because the fluid, as the fluid leaks, it's leaking from both the cochlear part and the vestibular part. However, when we talk about benign paroxysmal vertigo, you have these semicircular canals in your vestibular systems, okay? This has fluid and it has a receptor here, okay, which detects the motion of the fluid, okay? Sometimes you get a stone and you don't want that. So as fluid moves, it will push the stone, and as the stone moves, it will create turbulence. So it will lead to an improper detection by the sensory organelles. Hence, the signal carried to the brainstem will be not that which is true, okay? And hence, you will have vertigo, okay? So this is benign paroxysmal vertigo. I'll show you images in a bit. And the way you treat it is you want to take the stone and carry it out, okay? This is called Epley's maneuver, and I'll explain it in a bit. And the episode is usually for seconds, because as the stone moves, it's for a few seconds, okay? Meniere's disease, when you have overproduction of the fluid, and we said this fluid is shared by both the cochlear part and the vestibular part, so you have hearing symptoms, you can have hearing symptoms. Migraine associated, we'll talk about it. The others are usually for days, they're due to inflammation. If you had a tumor, if you had ototoxic drug reaction, these are all other causes, but the main ones are the Meniere's disease and the PPV. You should be able to differentiate between them, okay? You differentiate between them depending on the timing and the hearing involvement. So let's talk about benign paroxysmal vertigo. So the main problem is that you have a stone in the, I wish I had, okay. So you had, this is the vestibular system. There's fluid here, and a stone will form here, okay? As you can see. As the stone forms here, and you move your head, the fluid will move. However, you will not get the corresponding signal from the receptors, okay? Because there's a stone, it will affect and create turbulence, okay? This will create vertigo, tamam? And the way to treat it is that you want to move the stone throughout this circular canal back to the, out of the circular canal, okay? And that's how you treat it. And in order to test for it, you use something called Dix-Hallpike maneuver. The premise of it is you want to move the stone. So as you move the patient's head, you're moving the stone in the vestibular system. And when you move the stone, it's going to create signals, which is going to create nystagmus. Okay, so you'll see the eye shaking. And this is how you test for it. Now, the episode, as we said, is less than 1 minute. There isn't any hearing symptoms. And when we want to treat it using the Epley's maneuver, we're just moving the stone outside the canal, okay? You will learn more about this in the head and neck block, tamam? So this is the shape of the stone in microscopy. Just know that it's for a few seconds and it's due to stones, that's it. Meniere's disease is when you have a lot of fluid in the vestibular system. So you have in the vestibular system, when there's overproduction of fluid, as you can imagine, this is not going to relay the signals that are reflective of the true movements, okay? And they're associated with hearing loss, and the episode is more than 20 minutes, okay? So just understand the concepts. Don't understand the pathophysiology of it just yet, but for now, understand the concept. So you have a problem in the vestibular system, either due to a stone or either due to too much lymphatic endolymph production, and these are going to cause improper signals to be relayed to the brainstem, and hence these will be reflected through by nystagmus through the eye, okay? Because it's all linked. And there are different things you can do to test for the Meniere's disease. So you can do an audiogram, since we said it's associated with hearing loss. You can test for the hearing using an audiogram, and this is it shown here. Just know that if you have hearing loss, it's more likely Meniere's disease. An ENG basically attach these electrodes which detect eye movement, and you start injecting cold or hot water inside the ear. Okay, let me show you a picture of that. Hopefully that will be better. Yes. Okay, so you inject cold water inside the ear, and as you inject water inside the ear, what's going to happen is that you're going to slow down the endolymph inside the vestibular system. So it's going to create a signal which is going to cause eye movement, okay? So the premise is that if you inject cold water into the left ear, okay, in this case, if you inject cold water into the right ear, you're going to get a slow movement of the eyes towards the cold water, and then a fast movement away from it with nystagmus, okay? This is the normal test. So this is what happens if the vestibulo-ocular reflex is working, okay? The opposite is true. So if you inject hot water into the right ear, you're going to get slow movement away and then fast movement towards the hot water, okay? So once you see this test, you can tell that the vestibulo-ocular reflex is working, and it will further help you towards the diagnosis. Okay, so it will further help you towards the Meniere's disease. Temporal bone histopathology, as you know, the inner ear is found within the temporal bone, and when you have more in the lymph production, the inner ear is going to grow, and hence you might see that reflected on the temporal bone histopathology. Okay, as we said, this is the goggles which we talked about to help you see the eyes clearly. Multiple sclerosis is another differential in which you see vertigo. So if you have any damage in the white matter tracts of the vestibulo-ocular reflex, you will have vertigo. Other symptoms are optic neuritis, so visual problems. You will have sensory loss or motor loss through spasticity. These are all will help you diagnose vertigo due to multiple sclerosis. And then you have something called internuclear ophthalmoplegia, and this is due to damage of the longitudinal fasciculus. So as we said, you have the vestibular system. It's connected to the abducent nuclei, and then the abducent nuclei will is connected to the oculomotor nuclei through the medial longitudinal fasciculus. So the medial longitudinal fasciculus coordinates these movements. When you have damage to the medial longitudinal fasciculus, this is what happens. You want to turn your head to the, in this case, you're turning the gaze towards the left, and both eyes are doing that. However, when you have damage to the right medial longitudinal fasciculus, and you want to look to the right, what's going to happen is that one eye is going to be able to look, the other one is not, okay? So you don't have that coordination anymore. And this is usually seen in multiple sclerosis and will help you towards the diagnosis. Let's see. So we've talked about 3 diseases so far. This is what we were talking about. This is the medial longitudinal fasciculus damage. And then the fourth cause of vertigo is migraine associated. So as you know, you have 3 types of headache. You have tension headache, migraine, and cluster headache. You have more. There's the one due to sinuses and other types of headaches, but these are the 3 main ones that they like to ask about. So tension headache is your day-to-day headache. It's usually due to stress, and it's in a band-like formation around your head. Migraines are usually in half of the head, and they're associated with photophobia or phonophobia. And then cluster headache are usually retroorbital with autonomic symptoms. So you have lacrimation or sweating and so on. And this is how you tell the difference between the 3 types of headaches. Now, usually with migraines, you can get vertigo. So the patient will come to you with head pain, okay? And with a headache, with a headache and vertigo. This is more likely to tell you that it's a migraine associated. What's important is that now you've established an idea about each and every one of the 4 causes. So we said PPV is the episode is short in duration. Meniere's disease is long in duration with hearing symptoms. Multiple sclerosis, you have visual symptoms. You have spasticity, vibratory loss. And then migraine associated, it's associated with a headache. Since it's a migraine, you might have photophobia or phonophobia. These are other history parts of the headache. Now, other causes can include vestibular neuritis. It's usually due to a viral infection, okay? And you get inflammation of the vestibular nerve. It can cause vertigo since it affects part of the vestibulo-ocular reflex. And the way you diagnose it is through a temporal bone histopathology. It will show scarbus, ganglion, neuronal loss. This is not important. Just know, vestibular neuritis can cause vertigo, and the way the way it is, it's a peripheral type of vertigo. It's not central per se. Schwannoma is a peripheral nerve tumor. As you know, cranial nerve 8 is a peripheral nerve, and when you have a tumor of the cells that produce the myelin sheath, that's called a schwannoma. And if it compresses on the vestibular nerve, you're not relaying the signals towards the brainstem, and you will get vertigo. Usually you have a bilateral schwannoma in the NF2 disease, okay? This is an MRI picture of it. You can see this is where the cranial nerve 8 comes out, and you have bilateral schwannoma. It's most likely due to neurofibromatosis type 2. This is its gross appearance. And since it affects the vestibulo-ocular, we're always going to come back at the end of the day to the vestibulo-ocular reflex. So if that's affected, you're going to get vertigo. Other symptoms, since it's compressing the cranial nerve 8, it's going to affect the cochlear part. So you're going to have hearing symptoms. If it compresses the trigeminal nerve, you're going to have facial loss of sensation. If it affects the facial nerve, you're going to have paralysis, and so on. Now let's talk about the central causes. So schwannoma is considered a cause of peripheral vertigo since it's a peripheral nerve sheath tumor, while compared to the vertebro-basilar insufficiency, so when you don't have enough blood flow to the brainstem, especially the part of which contains cranial nerve 8 nuclei, that is when you have vertigo due to a central cause. Okay, we've talked about this. Basically, the number one cause is called Wallenberg syndrome. As you know, the cranial nerve 8 nucleus is located in the medulla, especially in the lateral part. Okay, and when you have less blood flow due to posterior inferior cerebellar artery insufficiency, when you don't have enough blood in that artery, or an infarction or atherosclerosis, that part is going to get ischemic, and hence you will have death of the vestibular nuclei, and hence you will have vertigo. Okay, and the patient will usually have risk factors for atherosclerotic disease, so he'll be a smoker, old age, high cholesterol, and so on. You can test for it using an MRI. This is a T2 MRI, or angiography. Okay. Other symptoms. Now you will have inability in coordination, difficulty swallowing, hormonal symptoms, pain or temperature sensations. You should be very good with these. But the reason why I'm saying this is because these will have tie-ins with your anatomy lectures. Okay. Now, the way I want you to know this, and please take the time to look at this video. It's a brainstem mnemonic video. It's a certain way you draw the brainstem. So this is the lateral side. This is the medial side. And then you have your midbrain, pons, and medulla. As you can see, the cranial nerve number 8 is technically located between the pons or the medulla. So any damage to either of which can cause a cranial nerve 8 damage. And if you have the lateral medullary damage, that's called Wallenberg syndrome. So this is basically a drawing that draws the location of all the nuclei relative to the cortico-spinal tract, to the dorsal lemniscal pathway, to the sympathetic tract, and the spinothalamic tract. Now, when we talk about Wallenberg syndrome, you have lateral medullary damage, and you will get symptoms of cranial nerve 10, cranial nerve 9, cranial nerve 8, and cranial nerve 5, okay? Along with the sympathetic tract damage and the spinothalamic damage. If this does not make sense, please go and watch this video. It will help you a lot, especially in your anatomy lecture, okay? So this explains the Wallenberg symptoms. What else? So this is part of the central vertigo. Now let's talk about other causes of dizziness. So vertigo can cause dizziness, okay? But other stuff can also cause dizziness. Now, the difference between dizziness and syncope, so it's on a scale. Dizziness is very light. It's doha in Arabic. And syncope is when you have loss of consciousness, okay? They're usually due to either vagovagal activation. So when you have severe bradycardia due to high vagal activation, or when you have orthostatic hypotension, so due to volume loss or certain medication. Now, these are not important for neuro, but when it comes to a differential, when a patient comes to you with dizziness, it's important to have these in the back of your mind. So I'm just going to skim through them. You're very familiar with them, I'm sure. You have your autonomic system, which coordinates the blood pressure. If you don't have enough blood pressure, the patient will be lightheaded. That's the premise of it. These are the causes. So if the patient had arrhythmia, or he had a volume problem, or he's taking drugs, if he had seizures, or if he had diabetes of some sort, so he does not have glucose, so he'll be lightheaded. And these are differentials for vertigo. Again, they're not important. They're usually seen in elderly, because the elderly population have certain features, such as their baroreceptors are less sensitive, they have less fluid reservoir, less vascular tone. Just keep these in the back of your head. I'm not asking you to memorize them. The main thing from this lecture, if we went back, the main thing is to know a little bit about each and every cause of vertigo. So you know the 4 causes of vertigo usually. You know how to differentiate between them. This table is very important. You know the meaning of each and every test, okay? So you know the head thrust test, you know the Romberg test, you know the visual acuity test, and how it ties in with the vertigo. If you have those in the back of your mind, you know how to differentiate between peripheral and central. I think that's the main takeaway of the lecture. I'm just going to go over the rest of the slides for completeness sake. But if you have those in the back of your head, you're done. That's it for the lecture. Move on to the next one. So where did we stop? So we said that the elderly are more prone to autonomic dysfunction, and hence they are more likely to suffer from orthostatic hypotension or from lightheadedness. So orthostatic blood pressure changes basically means you don't have autonomic regulation. So as you change position from lying down to standing, your blood pressure changes accordingly, which shouldn't be the case. Your blood pressure should be constant. But when you have autonomic dysfunction, that's what you get. Imbalance is also another thing that the patient might come to you. You want to see if that's related to vertigo or not. So here are the causes of imbalance. There is this certain flow chart, but part of it is vestibular region, and that will tell you that the imbalance is due to vertigo. However, it can be due to cerebellar lesion. So let's talk about the cerebellum. The main things about the cerebellum, you're probably good with this from your anatomy, are the flocconodular lobe and the corpus cerebri, okay? So the flocconodular lobe coordinates your head, okay? Your head and your eyes, okay? While the corpus cerebri will control the unconscious proprioception for the rest of your limbs, your body, your posture, and that will help you understand, okay? So we talked about this. So the vestibulocerebellum coordinates your head, your eyes, and part of your trunk. The rest of it is coordinated through the other part of the trunk is coordinated through the anterior lobe or the appendicular, and it coordinates also the limbs. So that's the function of the cerebellum. It's responsible for the unconscious proprioception. And the way it presents, if you had any damage to the cerebellum, it will present as ataxia, or as a tremor, or as hypotonia, okay? And the tests for it are very important. So these are the tests for it. And I want you to differentiate between them and the dorsal lemniscal pathway damage, okay? So when you have a cerebellar lesion, the 2 main diagnostic tests are finger to nose test, okay? So he will not be able to coordinate it, and heel to shin test. And then there's the dysdiadokinesia, where you ask him to do like this, okay? So he will not be able to coordinate it. This hints towards a cerebellar damage. And this is compared to Romberg test, which tells you that there is dorsal medial lemniscal pathway. Both are responsible for proprioception. However, the cerebellum is responsible for the unconscious proprioception. It's important that you are good with this. And so basically, you need to know how to take history from ataxia. It will hint towards the diagnosis. These are all the diagnoses that can cause cerebellar damage due to infection, due to certain congenital diseases, due to tumors. I don't want you to know this. Just know the vertigo, the first few slides, which I told you about. Other causes of cerebellar, how do you test for cerebellar ataxia? You can use an MRI to visualize the cerebellum. You can use ENG testing, which we've said. And in case you had an infarction, as you can see, this is an infarction of the cerebellum. you can use the tests we've talked about. There will be ataxia and nystagmus because you have your eye movement is coordinated by the inferior part of the cerebellum, and any damage to that can cause nystagmus. Tremor is another symptom. It's very important to know that the hand-to-shin test is how to diagnose cerebellar lesions. Other damage to the cerebellum can be due to hemorrhage and tumors, okay? So the main point of the lecture is that you have your vestibulo-ocular reflex between your oculomotor nerve and your vestibular nerve, which are coordinated through the brainstem. If they're affected in any way, shape, or form, that's going to be reflected by vertigo. It's important to differentiate vertigo based on its causes, peripheral or central, from other causes such as lightheadedness, because the patient will come to you with, he'll tell you, I have doha or dawran, but you can't diagnose him based on that. You need to take history, you need to do certain exams, and this can help you in the diagnosis. So that's it for the clinical lecture. The main point is to differentiate between the diseases and know the diagnostic tests. If you're good with that, you can easily answer all the questions, which will be 2 during the exam. I'm sorry if I lost you, but yeah, I'm ready if you have any questions. Hello, can you hear me? Hello. Okay, so Sarah's asking, what is a possible example of those questions with the diseases? Okay, so the way they ask you is they tell you to differentiate between, so they'll give you a scenario, okay? They'll tell you to differentiate between benign paroxysmal vertigo and Meniere's disease, okay? So how do you differentiate between them? By looking at the episode, by looking at the hearing symptoms. So that will be, they'll bring you a list of differentials and that's it. So it's going to be a straightforward question. It's not going to be hard. So yeah, I highlighted 2 slides. If you know these, you can move on from the lecture. Don't spend too much time on it because I promise you have way better things to do. If you're good with your anatomy, you can, and your pathology, you can skip clinical between us, okay? And that's it. Thank you. If no one has any questions.